Right, well, thank you to SAGES for the opportunity to present and for giving me a little bit of time to carry on. So what we would like to present today is our information with regards to paraesophageal hernia repair in the setting of patients who have chronic anemia, microcytic in nature. I have nothing to disclose. So as was already alluded to, the background between paraesophageal hernia presence and anemia has been well documented in the literature. Cameron's lesions are a notable suspected etiology of chronic blood loss and anemia, and some of these studies impressively go back to the early 1900s. That being said, evaluation, indication for surgical repair, and outcomes in this subset of patients remains somewhat obscure, especially in those patients who have no other symptoms other than the anemia. So the objective of our study was to characterize anemia resolution rates after paraesophageal hernia repair with respect to the preoperative endoscopic findings and the overall anemic status. This is an attempt to help clarify the management algorithm in this subset of patients. So for our methods, this is a retrospective review of all of the patients who underwent paraesophageal hernia repair at UCSD from 2007 to 2018. Paraesophageal hernias are well defined. Anemia classification was similarly according to WHO guidelines. We also included patients that are actively treated for their anemia with iron supplementation. Preoperative evaluation in these patients were upper endoscopy and upper GI series as our norm. Some patients did come with other imaging from outside hospitals. Our demographics are here. This is the 56 patients included who had anemia. The age median was 65. There was a propensity towards female distribution. The mean BMI was around 28. You can see the classification of types of paraesophageal hernias. There were two complications. One of these was a pneumothorax that was managed expectantly, as well as one patient with dysphagia requiring dilatation. Our in-hospital and perioperative mortality with regards to this surgery was 0. We had a median follow-up of these patients of 160 days. All of these patients, to go without saying, underwent a minimally invasive approach with complete surgical reduction of their hernia, intra-abdominal length achieved on the esophagus, and they had a fundoplication, either partial or complete, as well as primary repair of the crura, and either at the beginning of our study, a biologic mesh was used, and then we moved on to an absorbable synthetic. There were 154 patients who underwent this repair. 56 patients had documented preoperative anemia. For whatever reason, it was difficult to ascertain from the chart review. Only 50 patients had a preoperative endoscopy. Our suspicion is that a few of these patients did come to us in an emergent setting. The overall resolution of anemia within this group of patients was 26 out of the 56 patients for 45% resolution. Now, as we looked closer at the endoscopic findings, the breakdown kind of showed us, yes, Cameron's lesions are common. Our rate of detection was approximately 32%, which is in keeping with the literature. Gastric ulcers could be also associated. It could be a nomenclature issue, but there were 6 patients that presented with gastric ulcers. Gastritis, Barrett's esophagus, and esophagitis were also noted on the upper endoscopies preoperatively, and there were no findings aside from the paraesophageal hernia itself in 36% of the patients. As far as our results, we can see here that our resolution rate is a bit more conservative. We had 26 out of the 56 patients showing resolution, putting it just under 50%. But when we look a little bit closer, we can see that although not statistically significant, Cameron's ulcers, with or without combining gastric ulcers as being a similar etiology, showed more in range of 66% of resolution, but our p-value did not quite support this. I think what's a good takeaway when we're counseling patients here is that esophagitis, as was alluded to in the previous talk, does not seem to be associated with a causative source of anemia in these patients and did not show any resolution with repair of the hernia. More interestingly for us was that 13 of the 18 patients who had no preoperative endoscopic findings did show resolution, and that's a rate of about 72%, and it was statistically significant from our assessment of under a p-value of 0.05. We then looked closer just to see how are we diagnosing anemia. Does it make a difference if you look at hemoglobin values versus their treatment with iron? And for this breakdown, it did not. We still achieved resolution in 18 out of 40 patients, so just under 50%. And when we looked at the patients that were diagnosed based on their use of iron supplementation, it was a 50-50 shot, 8 out of 16. There are limitations to this review. This is a retrospective data analysis. The sample size is, still low in the 50s, but that is a good, pretty good for this type of patient population. Preoperative evaluation for obscure bleeding. There is some literature out there that can highlight whether or not we should be more aggressive in full diagnosis, including capsule endoscopy and those kind of tests. We feel that our patients were worked up appropriately so, because you also get to the other side where you're doing more testing than economically or clinically useful. And also, missed lesions depending on the timing of different tests. Objective follow-up is always a challenge in these patients. It would be interesting to get them all back for repeat upper endoscopy. Whether or not it would change our management plan is yet to be determined. Conclusion from our study here is that paraesophageal hernia repair can lead to resolution of anemia in about 50% of patients. So again, a little bit more conservative of a number. The preoperative detection of endoscopic lesions does not necessarily portend to a more favorable outcome with regards to resolution of the anemia, given the fact that we found a higher resolution rate that was statistically significant in the patients who had normal endoscopy aside from the hernia itself. Therefore, refractory anemia with a patient that has a paraesophageal hernia could be considered an additional indication for repair in the absence of other symptoms that do occur with large hiatal hernias. Thank you so much.